Okay, so you didn't have, I couldn't find my chest tube podcast, so you're going to get a video or a screenshot recording for the chest tube. This chest tube is what you're going to see the most of this semester, basically because this is what we use in adults, and I think if a peds patient has a chest tube, they're automatically in PICU, so that would be level 3. So let's just look at this chest tube and we'll go over what each thing does, A through E. Okay, so you have the suction port. If the doctor orders suction, this is where you connect the suction. Now, I'm sure you can see that. It's pointing right there at it. Sometimes it's just to water seal. So this area down here is your water seal, and that just prevents negative pressure from escaping. We want to return the pleural and visceral lining, that space, back to its normal negative pressure of -20. So if you actually have this connected to suction, it's automatically preset at this -20. So it doesn't matter how much you turn the wall suction up. It can be on full suction. It will not do more than -20 suction on the actual chest tube itself. But you need to turn it up more on the wall than -20. So ideally they're saying in the medium to high or full suction range. If you are connected to suction and it is working properly, then this little accordion orange thing will be viewable and expanded in this window E. So A is the amount of suction. B, this is your chest or intrathoracic pressure. Okay. Usually it's going to be in this area down here. That little white ball will usually hang more in this area. If they cough, it'll shoot up. If they take a deep breath, it'll shoot up. So anything that increases that intrathoracic pressure will make that little ball go up high, but it should come back down. If it does not, on the back of this chest tube is a little plastic button, which doesn't really look like a button, but you push that and it'll bring that intrathoracic pressure back down. So very important. If it goes right back up, that means you might have a kink in your hose, you might have a clot in your chest tube tubing, so you really want to start troubleshooting. And anytime you're troubleshooting, you work from the patient to the equipment. So always start with your patient. What do they look like? What are they doing? Are they in distress? And then work towards the end system or equipment. Then your drainage, so this tube is actually what's connected to the patient's chest tube. So it's really long and it's coiled on the back of it when you take this out of a package. And your drainage will come through there. It starts in this chamber, okay, and when that chamber gets full up here, then it'll roll over to the next chamber starting at the bottom and working up, and then keeps going until it's full. Ideally, you want to know how much output your patient is putting out about every hour when the chest tube is new. Sometimes in the recovery room, this thing is filling up really fast. So sometimes the doctor will put down, notify me if patient is putting out more than 100 mils per hour or 200 mils per hour times 2 hours or something to that effect. A lot of times they'll go ahead and write parameters so you'll know whether to get excited or not. So the main thing to remember is when you have a patient with a chest tube, you'll want to know what level the drainage is at when you take report from the outgoing nurse. So if she says the level is at 500, when she checked it with INOs, and then whenever it gets close to the end of your shift, then you'll mark your level, say it's at 700, and then your actual output was 200 mils for the entire shift. So that's what you document. You may have two different, you may have the level that you document and the actual output that you document. And then that's the level is what you tell the nurse that's coming on, and then of course how much they're averaging on the output. In the beginning, the drainage is always sanguineous, it's just blood red. It can clot easy in that tubing. So this will come when you take it out of the package. There will be a vial of sterile water on the back. You do squirt that water into the suction port, and that will add it to the water seal chamber down here, number C. Now this water seal chamber is what prevents air from going into that pleural lining, that space between the visceral and pleural lining. If there is an air leak in the system, then it will have continuous bubbling down here in that water seal chamber. Okay. If the patient has a pneumothorax, say that's the reason why it was put in, then you will have bubbling. It's usually on end inspiration as that inside of the lung is pressing out. The lungs fill out, pressing out on that outside layer and forcing air out through the tube, through that water seal. So that's usually when you see bubbling. And we'll talk about the degree of bubbling when I get this to scroll down. Okay, so we look down here. So this is the connector that connects to the actual chest tube. So this is your clamp. And with this connector that connects to the chest tube, in the recovery room we actually put safety ties on there and cinch it down with a little gun device, and then it clips off the excess safety tie. So what they show you in Taylor's book as far as the double Kelly clamp is not necessary, because where we're changing the chest tube is at the top of the collection chamber where I pointed out just a moment ago. So you can kind of see it right here under that arm. So we're just changing out the collection chamber itself and not the actual tubing on the chest tube, unless there ends up being an issue with that, and then you end up having to splice. That's when you would do the double Kelly clamps, and we always send 2 Kelly clamps with each chest tube from the recovery room, and you want to keep those handy. So yeah, here it shows that you want to set your wall suction greater than -80 minimum. So again, the machine itself has that suction setting, and it won't let more suction go to that patient, to the pleural lining, than the actual collection chamber is set for. So how will you know your patient's having problems? If they say they have chest tightness, more than likely that means there's a kink or a clot. If you let this tubing from a chest tube, where it goes from the chest tube on the patient to this collection chamber, if it has a dependent loop the laws of physics will prevent that from draining very well. Because of hydrostatic pressure, it can't rise up, especially if it's on water seal, because there's no suction there. So, of course, blood products clot whenever they pool. So we want to prevent any pooling of the actual chest tube drainage, because if it has any pinkness at all, there's blood cells in it, blood cells clump. So you can pull it up on the bed, kind of lay a flat loop on the bed before it actually goes down to the chest tube, and that will help prevent those clots from forming in the tube. Now you can manipulate that soft rubber tubing to empty into the chest tube. And you probably may have seen some patients with chest tubes last semester or in the summer if you were on 8 or 9 West. And again, we always start with the patient workout. Now, the level of bubbling is right here. You have 1 to 5 on the bubbling. So that's basically a gauge for you to go by. So when you're documenting, you can say patient has end expiratory or end inspiratory bubbling, and you can put level 3. So if it's bubbling all the way out to here, get that to right, then that would be level 3. So 1, 2, 3, moving from right to left. This is your water seal level right here, that little white dotted line. And basically, if they're having a lot of bubbling, evaporation can occur. So you want to make sure your level is on the line. Now, on the back side of this, there is a little rubber port. So if your patient's on suction and the doctor doesn't want that suction stop for anything, then you can actually add some sterile saline to the water seal using the rubber port on the back of this. And I'll show you that in just a moment. For the purpose of lab, this little blue slide clamp is what we use to clamp the tubing prior to changing out the collection device. And as soon as you change out the collection device, then you have to unclamp that before you reapply the suction. If you don't unclamp that, or if you don't reapply the suction in that specific order, then that is a fail. So it's just remembering to unclamp that chest tube, because that intrathoracic pressure will just keep building. And then if they do have a pneumothorax, that'll continue to get worse. Okay, so here, right there, is that little rubber port I was talking to you about. You can just use a blunt needle. Some of the newer ones actually have a Luer lock port on there, so you don't even have to use a needle. You just use a Luer lock syringe. So yeah, but otherwise for new setup, this is how you add water to the new setup. And that little vial is taped right here on the back of the new chest tube setting. And again, you connect your suction after you add your water for the water seal, and you put the entire vial for the water seal in order for it to get up to that specified level there. And minimum of greater than -80 on the suction. Full suction's fine. Again, this little setting here will prevent it from getting any higher than -20. You have a little kickstand, or you have these hooks right up here. They're kind of folded into the handle, so you can hang it from the bed. If they're going to be traveling, we usually have them travel by water seal. So usually the doctor is getting a chest x-ray pretty much every day just to see how the pneumothorax is resolving. And once it's almost resolved, then a lot of times they will just go to water seal before they actually discontinue the chest tube. So they'll discontinue the suction, usually the day before. They'll get a chest x-ray that next morning, And if the pneumo is stable or has resolved, then they'll DC that chest tube. Now you can assist with or observe the chest tube being removed, but you are never actually to ever remove a chest tube on your own unless you go for advanced practice. So that's always a good thing to see as your patient's getting better. Let's see, thoracotomies, thoracoscopies, pneumonectomies, they will all have chest tubes as well. Basically, sometimes the surgical process, air is introduced into that pleural lining. You'll have extra drainage from the surgical procedure. Normal body sends all that fluid to the area of injury. So you expect more drainage in the beginning, but that should be coming less and less and less as the patient heals. And again, you're looking for that continuous bubbling. And we'll do the hands-on on the lab as far as hunting for the leak if you have continuous bubbling here in your water seal. Okay? But again, it should never be continuous. It should just always have a respiratory pattern. And they don't show the little circle release up here that we can drop that intrathoracic pressure ball that goes up and down here. And we'll learn more in lab. Thank you.